irritability, right? Heart muscle may cause abnormal contractions, dysrhythmia, form ectopic foci, tachydysrhythmias. EKG analysis should be done on any patient with a cardiac condition. If they told you they've had a heart stent or they've had cabbage or they've whatever, you should be putting them on the monitor right away. So, EKG monitor can be used to monitor them during transport. We want to print the dysrhythmia strip. We want to print the 12-lead EKG for diagnosis. And Sherry brought up the same cases. Do you always believe what the 12-lead monitor, what the LifePak 12 or LifePak 15 tell you is the interpretation?
No.
No. Because they could be totally wrong.
I think it's STEMI like 40% of the time. And that's coming from the guy from physio.
Right. Yeah. Right. You're exactly right. And it goes back to my comment is treating the patient, not the monitor. Okay? If it and my other thing, if it walks like a duck, it sounds like a duck, and you know, it looks like a duck, it's probably a duck. Okay. I'm just that way. If you're not an Eagles fan, you wouldn't understand. Sorry. Anyway. And then you was a joke. Okay, well, hey. Okay, so cardiac monitoring and using the and ECG usage. Okay, the 3 standard limb leads 1, 2, and 3 for continuous monitoring. 12-lead EKG provides detailed information about the heart's conduction system. Records activity from 12 separate angles. It's a snapshot. It's a tool. It's a tool to tell you what's going on with a person's heart. Okay, that's all it is. It's a tool. Okay. We didn't have them back. You know, when Sherry and I started, when I started, there was the LifePak 10s. We didn't have we didn't have it starting back then. You know, we didn't have the 12 leads, and now they're starting them. Okay, it does. We talked about this. The 12-lead EKG is an interpretation that the monitor is giving you, not you looking at it. Okay, it's very easy to transmit now. Okay, now with technology, we can get them in there if they're working or if the cells, the cell towers are right. We get them into the hospitals. The problem with sending a 12-lead EKG is, guess what? If their printer isn't set up right, they don't get the right capture of the 12-lead. When I called Bryn Mawr Hospital, I said, here, I'm sending you a 12-lead EKG. Oh, it was on portrait, not landscape. I'm like, some of these things you can't make up. You know, some of these things, when they look at it, they only get a small picture of it. And now one of your classmates was telling me that the new gold standard is it's actually like a body camera where you're able to talk to the hospital and have a conversation and have a face-to-face about what's going on with the patient as you're transporting to the hospital.
Anthony's adjust that.
Okay.
Cool, huh?
Predetermined spots for your EKG leads. You all know where they are. How many people put the 2 bottom leads right above the legs?
Sometimes.
They do sometimes. Where are you supposed to put them? Where are they supposed to get their accurate read? On your legs.
On your calves.
The limb leads, right? And then where do you put the upper ones? Arms.
Shoulders.
Between the shoulders and
Cardiologist puts them on your belly.
Yeah. Okay. It may be necessary to shave someone. Okay? Shave their chest. Especially if they're extremely diaphoretic. What else? Some squads, you guys carry tincture of benzoin? Tincture of benzoin?
Nope.
They're little swabs, brown swabs. It's called tincture of benzoin. and you put them on there to keep yeah, so here, is that tincture of benzoin? This is, yeah, here you go, tincture of benzoin. To put on the leads. Especially, how about in warm weather? You know, when you're sweating or you're going out. Okay, you have to use the towels and stuff, okay? Attach the EKG electrodes to the cable before putting them on there. Turn on the monitor and print a sample strip. Okay. I'm not going to say anything about that. Okay. There's times where you're going to get false readings. That it's going to look a lot like gibberish. If you see that there's a lot of artifacts on the monitor, what do you do? If there's too much on there, what do you do? I put all the leads on there, everything, I've done everything right, and I can't get a normal reading. I can't get anything. I get nothing or I get gibberish. What do I do?
You gotta adjust something.
Okay.
Tell them to stop.
You take it off and redo it, right? Go back and do it.
Make sure you're not driving.
That's true too. If you were driving, that would be
Tell a person to stop moving.
okay. Wavy baseline may be caused by movement and tremors. If people are too cold, that happens too. People, you can't get an accurate reading if they're moving too much. Okay, especially if they're very cold.
So how do you correct that for the
Warm
immediate?
them up. With what? Too much movement?
If they're just shiver shaking,
Tell them to stop.
you can't.
Okay.
No short term like.
Well, this is what we say. We warm them up. We use hot packs in their limbs, in their groin area, to try to warm them up. Okay, we do the best we can do. Really, it's the best we can do to try to get, an accurate capture of their heart.
With marshmallows.
That's right. Swiss miss. Swiss miss. Okay, limb leads. Leads 1, 2, and 3, AVR, AVL, and AVF. Okay, so you have the white that goes on the upper right side on right here, right? Chest and shoulder right here. That's the white one, and you have the black one that goes to the left upper chest, near the shoulder. We have the red one and the green one. Again, we've talked about, we want to make sure that they're on the actual limbs, right? We want to make sure that they're not so far down to the ankle, but we want to make sure that they're not so, some people get unfocused and put them down here. There's a lot of people that have done that and not gotten an actual capture, a good capture. Okay. So, here we go. For the actual 12 leads, so they have right wrist, left wrist, red is left ankle, green is right ankle. Okay. So what is this theory here? Does anybody know? Did anybody do a little bit of research for this one?
I know this triangle gives you your first 6 leads on 12. 1, 2, 3, AVR, AVL, and AVF.
Okay. Anybody want to add to that? Sounds good? Okay.
Put in triangle.
So,
Are you saying we should move the lead for 12 lead to the wrist?
well, you're getting a better capture if you go further down on this. If you're, for me, because again, I get seen by a cardiologist every 6 months, so I have them down here. There's a better capture the further you are down, the better capture. Okay? And that's what you're taught by. If you take the 12-lead EKG interpretation, there's a course on it that somebody teaches, and they talk about how to place it on your body. Okay, the AV leads. Okay, for the 4 limbs, leads AVR, AVL, and AVF combine 2 limb leads and use the other lead as their pole. So, right, what you said. Okay?
Good question. Are they showing that on the abdomen because they don't want to show the whole picture of the body? Because we were just talking about the limb leads being on the limbs? Or did I miss that?
What's that now?
They're showing the bottom two electrodes.
Well, they're
to be
showing
on the
how it
abdomen.
polarizes into this. All they're doing is the AVR goes. I was going to show you the AVR's here. So all your leads are down, right? Your 4 leads,
But
right?
they're really supposed to be on the legs, or they're supposed to be on the abdomen.
You're supposed to be on the. I like them on the legs. Okay. These are the. If you're doing a 12 lead, it's on the legs. AVR for these, they show them on the abdomens for this one here. Okay.
So what's the
But I
difference?
like them on the legs. A true 12 lead EKG, a true measure of everything should be on there. And so is that what's it saying into your book? What's it say on your abdomen?
The picture shows it on.
And the abdomen. But I think what they're showing is they're not going to show it to you all the way down on the legs.
So it's supposed to be on your legs?
Yes.
It says,
Yes.
for continuous monitoring, they're supposed to be on the body like that. And for the 12 lead, they're
It's
supposed
for
to
the
be
legs.
on the
Okay.
legs.
So continuous monitoring, if you're not doing a 12 lead, you do it on the abdomen. If you're doing a 12 lead, you're doing it on the extremities.
If you're using a life pack, their recommendation is on the legs. All the time.
Right.
I just put it on the
So
limbs.
we put them on
Try the
during
limbs.
testing
The
and
problem
stuff?
I feel is, I call it
Is that wrong?
obstacles, skin space is what I call it, so, because sometimes they're so dressed, you can't get in to get the boots on. So that's why you see them putting them on the torso a lot, because they can't get down to the legs, because the old ladies wear stockings and all kinds of girdles.
Girdles.
It's really tough. Preferably, as a student, go with limbs, and then if you can't, you may have to move,
So when we do our clinicals and stuff, is it
limbs,
all limbs? That's it?
yes, we're gonna do limbs. Yeah, so there's, but it depends on the
So limbs. You go with that?
Yeah, I just didn't know what the
I know.
difference
Yeah,
was.
that's why.
Okay. Precordial leads. The 6 additional leads for your 12 lead. Okay? So where are we putting them? What's the space on the 6 leads? Yeah, where do we put them? Where do we position them? That's what I was asking. Okay, what in where
Fourth intercostal space.
Fourth intercostal space. Okay? Okay.
B5 is midclavicular.
Anterior
Okay.
axillary.
So, right. So V4 is fifth intercostal space. V5 is lateral to the anterior axillary line, and V6 is lateral to V5. What's it showing you when you put this normal in this normal configuration? What is it giving you a snapshot of? What version of the heart? What side of the heart is it giving you a version of? Left side. So if you wanted this version of the right side, what are you doing? Reversing. And they talk about this. So, and posterior, and there's other things called 15 lead EKGs and 18 lead EKGs, which is like, do we have time in the field to do that? Yeah. No. Okay, so if you see there, so if you're looking normally, typically you're doing the snapshot. The 12 lead, you're setting it up to take a snapshot of the left side. Okay? So if you're doing the right side, it's V1 is left of the sternum, fourth intercostal space again. Same thing, only inverse on the right side. And then you have the posterior, evaluates left ventricle, posterior wall electricity, 3 precordial leads placed on the left posterior thorax. Has anybody ever seen him do that? I've never seen anybody ever do
Once.
that. I have never. I said we talked about the 15 EKGs. The standard is the 12 lead plus V4, R, V7, and V8. Allows a view of the right ventricle and the posterior wall of the left ventricle. 18 lead standard tracing plus V4R, V6R, V7N through V8. Again, I have never seen I've never seen an 18 lead EKG, but I will definitely talk to my cardiologist when I see him. Okay, unipolar versus bipolar leads. What does that mean? Give me that in English. Anybody? Unipolar versus bipolar. We're not talking about it. Anybody?
Bipolar leads have a negative and a positive pole.
Okay. One.
Leads 1, 2, 3.
And what? Leads 1, 2. Right. 1, 2, and 3. Contain positive, negative. Leads AVR, AVL, and AVF are unipolar. One true pole. Others are referenced against the combination of other leads. Okay, so here we're back to this configuration of Wilson's terminal of leads 1, 2, and 3, AVR, AVL, and AVF. What is Wilson's terminal?
The point where all the leads are set, all the views are set.
Okay. And then we have the other ones when we're looking at the 12 lead, you're looking at right here intersect, and then you have the frontal view and the back view of that, right? So that's the 12 lead right there. Okay, lead polarity. Bipolar leads have a negative and positive end. Lead 1 is the left arm, it is positive. Lead 2, left leg is positive. Lead 3 is positive. Okay. Wave moves towards a positive electrode deflection above baseline. Wave moves towards a negative electrode and deflection below baseline. So let's look at that. It's a normal PQRST, right? Normal wave, normal heartbeat. So positive, normal, isoelectric, positive then negative, and then we have truly negative. Questions? So the baseline represents electrically silent period in a cardiac cycle. What is that? What's the?
The refractory period.
Okay. No, also known as the refractory period. Perpendicular wave results in a perfectly flat line, a line with a positive and negative component, biphasic waves. Okay. Graph paper moves along the stylus at 25 mm per second. What is that? Millimeters per second. Now, one box is 0.04 seconds, one small box, and one large box is 0.20 seconds. So how many little boxes are in the big box? 5. 5. Okay, so vertical axis represents amplitude. Standard amplitude calibration is 10 millimeters per millivolt. Excuse me. Okay, so here's your EKG paper blown up. It has not changed. It only has gotten bigger. You know, Life Pack 5s were like really super small. The 10s got a little bit bigger, and the 12s and the 15s are the same. So if anybody's ever seen a Life Pack 5 or a Life Pack 10, you know what I'm talking about. They're really, really small. Okay? But it's the same concept. It hasn't changed in 25, 30 years. Okay? You're counting to see where it is. Okay? So this is just a picture of right here. This is 4 seconds, or 0.04 seconds. Here you go. Large box, okay, is 0.20. The EKG rhythm corresponds to all electrical events in the heart. Okay, so the P represents what in the heart?
Atrial.
Right? Depolarization of the atria to, fill me out. So the atria depolarizes, then what happens?
Sends a signal from the SA to the AV.
Okay, and then what happens? Walk me through it.
Then the ventricle depolarized.
Okay,
Then, ST segment.
Okay.
Depolarization ends and repolarization begins,
okay.
and then T wave is repolarization of the ventricle. And
Repeats. Right, so this is the norm, this is the normal way, right? We understand this is normal. Okay, how tall is this supposed to be? What's the normal?
$360 to 440 milliseconds.
Okay, and what's the length of this? Does anybody know this one? It's supposed to be the P2 PR, the PR, the PR.
120 to 200.
Two.
to the fractal.
Just want to make sure, just asking questions. So atrial depolarization, smooth, round, upright shape, normal duration, less than 100 milliseconds. Amplitude, right, as high as it goes here, is less than 2.5 millimeters tall. Okay, we said that polarization is 0.12 to 0.20 in duration. QRS, the Q, the R, and the S. Okay, so the atrium is fired, right, SA node to the, it just gets there. How does it get from the SA node to the AV node? Internodal pathways, hits the internodal pathways, fires down to AV junction to the bundle of His to the Purkinje fibers, right? And bundle branches into Purkinje fibers, right? Okay, so just trying to visualize all that. Okay, from the beginning of the Q wave to the end of the S, sharp pointed waves less than 120 milliseconds, right? Indicates that an impulse has proceeded normally. Okay, normally. The Q is the first negative deflection, the R is the first upward deflection, and the S is the downward deflection of the R wave. So, we're talking about the ventricle, right? At this point, right? Firing and resting, coming to a rest. The J point, where the whole thing rests, right? Right as we get to the resting point, as we start to do the, what did you say, the repolarization, which is the ST segment, right? The start of the ST, right? Okay. There you go. Okay. T wave represents ventricular repolarization. First half presents the absolute refractory period. Second half represents the relative refractory period. Absolute, relative. Meaning, what?
Absolute is when you can't possibly have any kind of firing, and relative is partial firing.
QT interval represents all electrical activity of one complete ventricular cycle. begins on the onset of the Q wave and ends at the T wave. Say it again. So, the QT interval represents all electrical activity. One completed ventricular cycle. Normally lasts 360 to 440 milliseconds. Okay. Here we go. Normal. This is normal. We're talking normal right now. P, QRST, P, QRST. Now, when we're measuring we measured what? The PR. When we're looking at rhythms, we're looking at measuring the PR intervals. Okay? We march them out. We see if they're normal or abnormal. So, we measure the QRS duration. We determine if the rhythm is regular. Measure the heart rate. PQRST. Okay. So, R to R, R to R. Okay, so you can go from the top of the spike, okay, to go between or the bottom. They show that. I've always done the one with the top going from top of the rhythm strip to look at it. One of the things you notice that, right? You go and I'm predating myself. We used I don't want to say calipers, but is it calipers? We used calipers to measure, to march them out, to see if they marched out correctly. Okay, so distance between R and R waves is always the same. Okay? So that's how we check for rhythm regularity. Measure the distance between R waves. If it's irregular, no two R waves are ever the same. Regularly irregular. R waves are irregular, but they follow a pattern. Where would I find an regularly irregular pattern? Okay. What else? Is there anything else I'll find a regularly irregular?
PVCs.
Okay. Yes. So, the 6-second method. Count the number of QRS complexes in a 6-second strip, measuring it and multiplying it by 10. Okay, so what's the heart rate?
50.
Okay.
Right?
That's one way of doing, right? Excuse me, I went down there. So 6 seconds. This is the way I was taught. Taking the strip and looking at it, and looking at the strip and showing that, and going from where the star is. Now you have to have it hit that solid red line. Okay? So there's the star. So you march it out. 30, 150, 100, 75, 60, 60, 50. Okay? So find the R wave, count off the sequence until the next R wave. If the interval spans fewer than 3 boxes, rate is greater than 100. If more than 5 boxes, a rate is less than 60. Say it again. So, find the R wave, count it off from the next one. If the interval spans fewer than 3 boxes, the rate is greater than 100. If the box has 5, then it's less than 60.
Where do they get the 300 from?
What you can do is you can count the big boxes in between 2 R waves and divide by 300, and that'll give you the heart rate.
How do you
So
know
like,
300
let's say you only
though?
have 2 boxes, you divide 2 by 300, you got 150. If you look up there, it matches up to that scale.
Or you can memorize them.
Or you can memorize the
Yeah,
scale.
EKG
which will probably
Don't let her see.
Okay, another way of doing it is the 1500 method. Count the number of small boxes between any two QRS complexes and divide by 1500. I've never, no, thanks. That's just not, I'll stick to that. Sorry. Okay, so, specific cardiac dysrhythmias. Okay, specific cardiac dysrhythmias. We know that normal is PQRST. Okay, we know that our heart rate is supposed to be between, what's normal? 60 to 100. Okay, that's normal. Now we're going to go what's not. Okay, the flow of electricity through damaged or oxygenated deprived tissues may appear as irregularities. Many can be traced back to ischemia. Most common cause of cardiac arrest. Most common cause of cardiac arrest. So, disturbances of the automaticity and conduction, tachydysrhythmias, and bradydysrhythmias, are life-threatening or not life-threatening by site from which they arise. So, you can have bradyarrhythmias, tachyarrhythmias, okay? And we're talking, they could be life-threatening or non-life-threatening. Okay, remember, I go back to my saying, treat the patient, not the monitor. Treat the patient, not the monitor. Okay, normal sinus. Intrinsic rate of between 60 and 100. Upright P, wave proceeding with each QRS. So for every P, you have a QRS. For every time the atrium is firing, the ventricle is firing right afterwards, right? In a normal interval. Okay? Everything is happy in Walt Disney World. Okay? Life is good. Okay, sinus bradycardia. Anything below the heart rate of 60. Upright P preceding every QRS complex. Is that a bad thing? Right. Not necessarily. Runners, people that work out could have sinus bradycardia. Okay. Some causes of sinus bradycardia. There's SA node disease. They had an anterior wall MI, which could stimulate vagal tone, increased intracranial pressure, beta blockers, calcium channel blockers, morphine, quinidine, digitalis. Okay? Your treatment should focus on tolerance and causes. What happened? Okay? So people could have an MI and get out, and then all of a sudden, you know, they have some issue with their SA node. Okay? So, medicines again, beta blockers, calcium channel blockers, morphine, quinidine, and digitalis. Okay, sinus tachycardia. Rate is more than 100. Upright P preceded by QRS complexes. Again, do you see anything that's irregular other than it's a faster heart rate, other than a faster rhythm? Nothing's really changed, right? You still have P with QRS, right? QRST. And then you have your, everything's the same. Okay, it's just getting faster. Okay, so, hypoxemia, metabolic acidosis, hypokalemia, and hypocalcemia may cause, can lead to this electrical instability. Circus re-entry may occur. What is circus re-entry? Does anybody know what circus re-entry is?
Or the full complex hasn't completed before it starts again?
Electrical impulses travel up pathways back into the atrium.
I wrote it down, so I'm looking for my notes. Okay. Cardiac arrhythmias are generally produced by one of three mechanisms. Okay, here we go. Enhanced automaticity, triggered activity, and reentry. I can't say it right tonight. Okay, which occurs when a impulse fails to die out after normal activation. So the heart persists and tries to re-excite the heart after the refractory period has ended. Okay, so they talk about rhythms like atrial flutter, and atrial fibrillation that can cause problems for this. Okay, and they talk about also talking about involving a bypass of that. It could be ventricular tachycardia after a myocardial infarct. So any type of rhythm, AFib, A-flutter, ventricular fib, or ventricular tachycardia can cause a re-entry and cause problems for it.
You take 5 minute break? We got that time?
Almost.
We got 10 minutes.
He's killing me. Okay. So we're going to talk about the SA node. What is the SA node also known about as? What's the SA node known as?
Pacemaker.
The pacemaker, right? It's the natural pacemaker for the heart. Okay, where does it sit?
In the atrium. Anterior atrium on the right side.
Okay. So we said, so give me the firing again of the heart. SA node
The AV.
through. Okay. Okay.
The internodal junction.
The internodal junctions, right. That's what I was looking for. Okay. Upright P waves precede QRS complexes. Sinus dysrhythmias. We're talking about the SA node. Okay, the natural heart pacemaker. Okay, more prominent with respiratory cycle fluctuations, increased filling pressures during inspiration, stimulate the Bainbridge reflex, increases the blood pressure, stimulates the baroreceptor reflex. Anybody know what the baroreceptor reflex is?
Baroreceptors monitor the pressure inside the carotid arteries and the aorta, and when they sense decrease, the pressure.
Thank you very much, Ms.
That
Hickman.
makes sense. That is it, I guess, someone is it.
Thank you very much.
Thank you.
I'm gonna choke on this jelly, man.
That's good. Okay.
Yes, you don't play.
Sinus arrest. What do you notice about this rhythm strip?
The drop of QRS.
What else?
Multiple gradient.
The whole complex, right? The whole complex, right? So if the SA node isn't firing, or there's a problem there, right? Because we said if the person had a heart attack, that could be one reason for the SA node not having ischemia, right? So not only can the heart muscle have ischemia, the SA node can have ischemia. So if it doesn't fire, this is what we have: the sinus arrest. We have that elongated pause. Common causes: ischemia of the SA node, increased vagal tone, Carotid sinus massage, use of certain drugs. Here we go. They may have to put a pacemaker in. Again, we're talking about the SA node, sick sinus syndrome. Okay, variety of rhythms, poorly functioning SA node. Increases sign of bradycardia, sinus arrest, and SA block. Alternating patterns of bradycardia and tachycardia. I'm taking a break. Go take a break.